as Anja mentioned, this is a little bit for me. As Anja mentioned, we're starting off talking about issues related to medical care and healthcare, and I'm delighted to have this wonderful panel here. We've got Janice Sabin, Crystal Brown, Tim Brown, and Sarah Goering who are going to be speaking. And let me start off introducing you to Janice Sabin. She is the Research Associate Professor at the Department of Biomedical, Informatics, and Medical Education here at the University of Washington. She's also an Adjunct Research Associate Professor at the School of Social Work and is affiliated faculty at the UW School of Medicine Center for Health Equity, Diversity, and Inclusion. Thank you very much, Janice.
Okay, so thank you very much. I have a cold, so please forgive me. I decided to kind of focus on the idea of managing implicit bias. It's an area that I work in, research as well as curriculum development, and talking about data collection and evaluation and metrics, because that's something that people often don't talk about. So my background is I have a doctorate in social welfare with an emphasis on health equity and social determinants of health. So I just want to ask you to look at this poster. This was the Red Cross Water Safety poster for 2016. And it went out to public pools across the nation in late spring, getting ready for, I see heads starting to shake, yes, getting ready for the season. And the whole idea was the Red Cross was trying to keep kids safe. And so this was a well-meaning group of people. And I don't know if you see anything here, but it's like being cool and being not cool. But it turned out that this ended up being a pretty racist poster. And not cool, the children were brown children, and the cool behaviors were, the little blonde ponytail girls. So the only bad, kind of not cool white person in this was an adult drinking a beer. So this went out to pools across the nation, and there was an instant, what? And then came the Red Cross apology. So they did not intend to offend anyone. They're committed to diversity and inclusion. Again, not their intent to offend anyone, and apologize for this inadvertent action. My guess was, because I work in this field, that this was a case of implicit bias being manifested in this poster. And I emailed them asking them to tell me how they developed the poster, but of course I heard nothing. But I'm sure it wasn't one individual who took it from concept to production out to the nation. So I'm guessing this was not a diverse committee developing this. There was no community advisory boards. So that's just my guess. So this is, in my perception, a case of implicit bias. And what is implicit bias? But attitudes or stereotypes that affect our understanding, decision-making, and behavior without it ever even realizing it. So we all embody this. We absorb messages from our culture, and we all have biases in areas, and we don't know they're there. So I'm just going to talk a little bit about implicit bias, also known as hidden bias, unconscious bias. And we hear these words kind of bandied about these days. So I've done research in areas, I've done large samples of Project Implicit data, looking at healthcare providers, so physician race bias, implicit bias towards lesbian women and gay men among many different kinds of providers, physicians' weight bias. I've done a study in the Indian Health Service on implicit race and weight bias and among people who treat overweight children in the Indian Health Service. Study of pediatricians, frontline mental health providers, looking at implicit stereotypes towards people with mental illnesses, and then clinicians in Baltimore, also race bias and race and compliance stereotype bias. So I'm going to talk a little bit about how our minds work. We make snap judgments and first impressions very quickly. This is just how our mind works. We have automatic associations that develop in our more subconscious mind. We absorb messages from our greater culture, and we are bombarded every day. I mean, billboards, magazines, news articles, television, everything. And then there's something called in-group favoritism. We automatically feel comfortable with people who we perceive as being more like ourselves. So this is another mechanism for bias. So just take a look at this for a minute, or less actually. And I'm going to quote a study that found that first impressions are made very quickly. And this was a study that looked at first impressions of a person as attractive, likable, competent, trustworthy, and aggressive. And they found that exposure to an unknown face, which you were just exposed to, and I don't know if you had any perceptions about those people in that slide, but to an unknown face for 1/10 of a second is enough to judge those 5 traits. So that is really fast. That's implicit. They gave people a full second, to do the procedure again, and they found that the judgment didn't change, but their confidence in the judgment did. So this is how our minds work. It keeps us safe in the world. It's just how we function. So what comes to mind? Just think about that, just quickly. So implicit and explicit beliefs, we hear these terms. So explicit beliefs is our value system. It's what we can tell people that we believe, it's what we believe, it's what we know to be true about ourselves. This is our rational, higher level thinking. We like to think we function at all times at this level, but we don't. Implicit attitudes and beliefs are more automatic, hidden. We're unaware they're there. It's our lower level thinking. And often it does inform our higher level thinking. I don't have time to get into the details, but I could talk a long time about this. Implicit bias in behavior. So when is this implicit bias that we all have, and I'm talking about me, affect our behavior? There's a lot of work that's been done looking at medical decision making and bias, and finding that even people with egalitarian beliefs can show prejudiced behavior in situations where there's clinical uncertainty or other ambiguity. Situational uncertainty generally, heavy workloads, fatigue, and pressure of time, and that describes our healthcare system. Implicit and self-reported or explicit beliefs may differ, and you can be completely unaware that you have contradictory beliefs. Even the most egalitarian people can hold implicit negative beliefs, and again, I'm talking about myself. There is a way to measure, one way, there's many ways, but the most widely used measure is the implicit association test, which some of you may be familiar with. It was actually invented here in the psychology department by Tony Greenwald, and it's housed at Harvard University and called Project Implicit. And people are just asked to sort and pair images and words as they appear on a screen very rapidly and getting at that real subliminal response. The race IAT, I think 5 million people have taken this test. And if there's an association of a white American face with the concept of good that is quicker than a black American face in the concept of good, then that's some degree of pro-white bias. And the majority of people who take this test show some bias. There are other areas, weight, age, ability, it can go on and on. Implicit bias is common, pervasive in society. Healthcare providers show bias similar to others, so, of course they would. This was a very interesting study that looked at racial bias and found that racial bias is contagious. And this is a really interesting concept to me. So just observing a biased person, and they were identified as biased by taking the race IAT, express subtle negative bias towards a black person can shift an individual's racial bias, an observer. So others' biases, the authors say, may creep into our minds and infect our behaviors. So that's a pretty staggering idea. The good news is the flip side is true also. We can shift to the positive. So bias is contagious, and so are egalitarian beliefs. And that kind of sets us all up to realize what role models we really are. This was a study that looked at medical students across the nation. And they were asked to take the race IAT in year 1 and year 4. So they were following bias among this group. And they looked at non-African American students and found that 49% reported hearing negative comments about African American patients from attending physicians or residents. That's staggering. And then those who had heard negative comments, this predicted an increase in their implicit bias over the 4 years. So, again, that's really interesting. There's been a lot of research in the past decade on implicit bias in healthcare, and I began my work about a decade ago looking at this topic. Many studies assess just whether bias exists because it's a very new area of research. There are some studies that look at the association of bias with clinical treatment and health outcomes, and the results are mixed at this point. I did a study of pediatricians and found that pediatricians generally had really weak implicit race bias. It was a small group of pediatricians in one location. They had a moderate implicit association of black patients as less compliant than white patients. And this bias was not associated with treatment recommendations for ADHD, urinary tract infection, and asthma. And this was done with clinical vignettes. It wasn't real-world assessment. We did find, though, that for pain, as pediatricians' implicit pro-white bias increased, they were less likely to prescribe a narcotic pain medication for the black patient, but not the white patient. And this was the appropriate treatment for this case scenario. And there's a lot of literature behind this that there is not equitable pain medication. So this was another study, and this is an important study because it was done in real-world clinic environment in Baltimore. And they brought the audio equipment right into the clinic room, primary care providers. And they found that for black patients, stronger clinician implicit bias favoring white over black Americans, so implicit race bias for black patients, had lower positive affect. Patients liked the clinician less, had less confidence in the clinician, lower perceived respect from the clinician, and there was more clinician verbal dominance, so the doctor talked more than the patient, so it wasn't equitable. And I'm just going to show you a few other areas that bias is introduced. So this was looking at course content in the first 2 preclinical years of medical school here at the university. A medical student did this study. And she looked at, I think, 749 slide decks. And she found that representation and imagery was not equitable. So for females, we're only represented 40% of the time, with the exception of reproductive courses. And people of color were represented 22% of the time, compared to 34% of the population being non-white. This was a study that was looking at clinical clerkship grades. So third-year clinical clerkship grades. This is high-stakes grades. This ends up being predictive of where people do their residencies. And they found that students who reported high-quality clinical clerkship experience had higher grades. But lower grades were associated with older age of the student, lower quality clinical clerkship experience, being non-white, being male, and less assertive. And the conclusion was we need more investigation. This is a highly subjective process. It's not a standardized process. And here's a study that looked at implicit race bias in employment and identical CVs for a lecturer post in a university. And they were asked to review and recommend 2 of the 4 candidates for an interview. And this kind of gets into that whole area of hiring. And white participants with high implicit race bias were 10 times more likely to select 2 white candidates for an interview than 2 non-white candidates. And credentials were the same. Higher implicit race bias was associated with more time looking at positive information in the white candidate's CV and less time looking at positive information in a black candidate's CV. So this is a potential mechanism how bias could impact this process. And again, very subtle. Sorry. So what do? We all have bias, I guarantee it. Me, everybody. So what do we do? How do we manage it? There are many ways to interrupt bias. So the first thing I'll say is, I've heard people say, well, we will just have everybody take an IAT, and then the people who really do poorly will either fire them or we'll put them in remediation, and, we'll force people to do this, and that is not the right thing to do. So we all have bias, and we can affect this implicit bias a little bit in laboratory settings for a short period of time, but if we worked hard on each bias we might have, it would be the only thing we do, because biases pop up all over the place. So kind of tailoring situations so that bias can't affect decision making, like that Red Cross poster. Where was the community advisory groups before this was launched? Where was the diversity on the committee that developed this? Probably not there. So there are things we can do. Collect data is my big thing. Know if there are inequities. Promote diversity. There is research that shows diversity matters and it makes decisions more accurate. Be aware of imagery that you're using in courses and presentations and that you're exposed to yourself. Awareness of in-group favoritism. Role modeling is important. Every single individual in this nation is a role model for others. Okay, I will move quickly. Improving communication, being more patient-centered. Understanding implicit bias, we all have it. Coming at it with humility. Developing systems of accountability. Reducing discretion and subjectivity in decision-making and developing standardized objective processes is really important. And just one example of metrics that I've been working on is looking at underrepresentation in medicine and faculty diversity. So underrepresentation means those racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population. And here at UW, I won't go through all the data here, we are 4.1% underrepresented minority in the School of Medicine for faculty, compared to our state population of 19%, USA 27%, and then nationally in medicine, 5.3% underrepresented minority. So, that's very staggering. So, we are doing training for all search committees. It's a presentation on implicit bias. We're surveying people in real time, and this is a mandate across the university, by the way, so all departments should be doing this. We're surveying in real time whether people find this useful. We're tracking whether committees are doing this or not on our academic HR form. We're assessing the diversity of the applicant pool by job search over time, collecting data for new hires and faculty data over time. We've developed courses. This is like shifting gears a little bit, but we have several courses that we've developed. They talk about understanding what is implicit bias. I mean, until people own that they may have this, people can just sort of go merrily along their way and not realizing that their biases can impact their decision making. So strategies to interrupt bias, and then skills building. A lot of the skills building focuses on building trusting relationships with patients, because once that's done, then care is much improved. We've done a course on improving healthcare for adolescents, stereotypes and why they matter. Adolescents are pretty maligned by the time they get to the doctor's office. Everybody's sure they're going to be rebellious and uncompliant, and so kind of busting the myths around that. And we have a course we've developed, Implicit Bias in the Clinical and Learning Environment, where we have pre-post tests. And then this is my last slide. So talking about metrics and evaluation, I encourage everybody, everything you do, to build in metrics and evaluate what you're doing. So it can be as simple as number of participants, whether or not people use best practices, pre-post knowledge, pre-post attitudes, explicit attitudes. I do not recommend anyone force anyone to take an IAT because it can be damaging. Skills improvement, baseline versus end of course, behavioral change, user experience, changes in outcomes. So there's many, many things people can measure, and I'm real into measuring things. So I'd like to know what I'm doing matters. So thank you very much.